Good evening, one and all. My name is Sonali Sharma. I'm working as product manager in international marketing for Translumina Therapeutics. Initially, first of all, I would like to thank each one of you who have joined us today evening. And with this, I would also, before I hand it over to the session, to the moderators and to the speakers, I would like to take a moment to just introduce Translumina to all of us who have joined us for the very first time. Allow me a second. I'll just share my screen. Translumina is an Indo-German medtech company. We were founded in 2000 and have since delivered over 1 million implants and over 50,000 proteges so far globally. With 6 partnerships, strategic partnerships, and over 3 manufacturing facilities in spread over 3 different countries, we are present with over 65 countries with our products. Our products are backed by certified R&D excellence, including our collaborations with German Heart Center. We are fully integrated cardiovascular device company with manufacturing in Germany, India, and Netherlands. We have our Germany production and Indian production dedicated to our stents, whereas for the Netherlands, we do have a dedicated facility for our PTCA and our drug-coated balloons. Our reach spans over 65 countries, and we have built our strong partnerships with leading hospitals, engineering institutes, and renowned cardiologists globally to drive innovation and impact. Translumina has further strengthened its technology portfolio with acquisition of Blue Medical Devices, which is a company in Netherlands. And with this, the acquisition gives us the access to a patented, innovative, and proven next-generation drug-coated balloon technology for us. Our desk manufacturing facility in Hechingen, Germany is backed, integrated, and hosts global regulatory training programs. We have facilities in India and Netherlands, which are purposely built for high-end medical devices like paclitaxel drug-coated balloon for Netherlands and stents for our Indian manufacturing plants. And all of these sites meet various certification standards. In collaboration with German Heart Center, we have also led our ISAR trials, landmark studies in interventional cardiologies. Our infrastructure includes Europe's largest animal testing facility and dedicated imaging labs for QCA, QCU, and OCT. With this, we are proud to be world's first and the only company with 10-year safety and efficacy data on our 2 desk platforms, which is Yukon Choice and also Vivo ISAR. This makes us the makers of world's largest and the longest study desks. With this, we look forward to a long-stayed partnership with you, our cardiologists, intervention cardiologists who have joined us, our partners who have joined us from across the globe to together explore the limitless possibilities that we have been driving so far. And with this, I would like to take a moment. Although Professor Sutsuli, who is the moderator for our session today, does not need any introduction, but I would like to take a moment and introduce Professor Sutsuli, who is the moderator of our session today. He is the head of Department of Cardiology, Heart Center, Lucerne, Switzerland. He has completed interventional cardiology training at Oxford Heart Center, UK, followed by his other medical education at the University of Basel. He has performed over 5,000 PCI procedures as an independent operator and currently performs more than 400 PCI cases annually, specializing in complex coronary interventions. He is among Switzerland's most experienced operators in intravascular imaging, including OCT and high-definition IRIS. He is an independent operator for TAVI, LLA occlusion, PFO, ASD closures procedures as well. Not just that, he also serves as principal investigator for key trials, including pre-NC, Absorb ISR, and also as local principal investigator for various international multicentral studies. He is also the global lead principal investigator for our SPARKS RCT as well. With this, I would like to pass on the baton to Professor Sutsuli to take the session ahead and introduce rest of our speakers for the session. Thank you.
Thank you very much for the kind introduction. It sounded like introducing Putin. It just sounded everything great.
It is, Florem.
So it's a great pleasure for me to have this role. I have a fantastic panel today, and I really hope that we will get some interactive discussion with all the really good topics we cover today. So we have. I didn't see him online yet, but we have Dr. Anirban Chowdhury, who will speak about ISR. Then we have Dr. Singhal, who would speak about patient selection in DCB. Then my friend Mohamed Egret, I just said I see more than I see my wife. I saw him last Friday, and now I see him again. I was at his meeting, fantastic talk, also about DCB. Then we have Carlo. I saw Carlo is here. He will be speaking about de novo lesions for DCB. And last but not least, of course, my good friend from Dubai, Dr. or Professor Abdullah Shehab. I usually see him on WhatsApp when he posts great pictures on his status flying first class. Okay, so now let me share my screen and I will have a start with my talk. So my talk is actually imaging guided drug-coated balloon use, but what I actually would like to underline after, because we saw now last weekend the publication of a solution de novo, and that was great because solution de novo basically showed, okay, well, we are not doing something wrong, but the trial, although it was non-inferior, it was not suggesting that people should now only do DCB. That was not the case because in fact, it showed we made it to non-inferior, but we made it somehow barely to non-inferior. And I think the reason is because maybe we just included patients who also do well with stents. And we saw that signal in red cage free, because I think the easier the lesion, the more difficult it is to be better than the stent. Where I see the role of DCBs, and this has something to do also with the Sparks trial, is using the DCB in following settings: chronic total occlusions, highly calcified lesions, long lesions, diabetes, bifurcations, small vessels, and of course in-stent restenosis, but which is already established. I think with these indications, if we do such a trial, then we might even be superior to stents in the short term. With easy lesions, we will be non-inferior in the short term, and maybe superior in the long term. But now back to my topic, which is lesion preparation. And I have named it myself imaging guide lesion preparation. This is not because I want to suggest that you should be always using imaging, but just to show you how imaging can help you and can make you better. And then maybe in the learning phase, you use more imaging, and later maybe you can use less imaging. If you want to speak about lesion preparation, we have to speak about lesion morphology. And I will start with the soft lesion. This is a lady who presented with a anterior STEMI, and she had a spontaneous recovery of her ST elevation while on the way to the cath lab. On imaging, you see that she has layered thrombus here and probably a plaque rupture which is covered with thrombus, and you can't really see into the plaque. Now, in this lady, because her MLA was so large, we did not treat her, but I brought her back, and this is the imaging. I brought her back after she had a pathologic exercise test, and you see she developed a stenosis in the proximal LAD. And on OCT, you will see that actually this is a soft plaque, and she just became tighter again. So we treated this lady. I used a small cutting balloon, which was way undersized, but just in order to create some cuts into this now beginning fibrosis. Then I use an NC balloon and then 3.5 drug-coated balloon. This was the final result. You can see the angiographic result is good. Also, the result on imaging is actually quite good, with good lumen. And we brought this lady back after some months to do a CT scan, and you can see on CT scan, it's all healed up and it looks fantastic. So I think lesion preparation in soft lesions, I can summarize, do no harm. If you go in with cutting balloons which are adequately sized, or if you go with very aggressive lesion preparation in soft lesions, then you very often induce thrombus, and very often you cannot end up having a DCB treatment, but you will end up putting a stent, and maybe even you have to treat the thrombus formation more aggressively. Now, if you go to the other extreme, which is the heart lesion, and I know that Mohamed will speak about this, I would like to just give you an idea specifically on lesion preparation. The calcium can have different phases. Calcium can be circular, and on the left side you see this nice calcium ring. In the middle you see a ring but within the stent, and this is also something which we see from time to time. And then on the far right you will see the calcium nodule. And this is very important to differentiate because the different morphologies will probably need different treatment. Now, how can we tackle a calcium ring? Well, there is basically different ways. One way is to say, I use IVL and crack the ring. The other way is to go and say, I use atherectomy and weaken the ring so I can crack it with a normal NC balloon. And the third way is to use an open NC balloon at high pressure and crack the ring. Now, if you use a balloon, independently if it's the open NC or a different balloon, the more difficult the setting is, the more difficult the anatomy, the more calcium you see, the more cautious you should be with your diameter. And in calcium ring cracking, I don't go by the vessel size, but I go by the ring size. So the ring size here is 1.7. So I upsize that by about 1 millimeter. So here I used a 2.5 balloon at 45 atmospheres, and you crack that ring. And now you can continue with a DCB. If this is within a stent, then again, you could use orbital, you could try to shave it, but it will be difficult because the rest lumen is quite large. And if you don't have a very good wire bias, then it becomes difficult. And in these cases, again, I think you could use shockwave to crack the ring, or you could use an open NC to crack the ring and gain some more lumen, and then, of course, not put a stent within the stent. Here you see the compliance chart of the open NC, and we published now last weekend, we showed the result of our victory trial. And actually what we showed was that we are non-inferior to IVL. So now we have quite a bit of options to treat heavily calcified lesions. Now, let me go back to one case. This is a case, as you can see, heavily calcified LED, heavily calcified LED here in that portion distal to the diagonal branch, here again. And in this case, I could not do imaging. The catheter was not crossing. So what I did was I used a 1.5 burr. We did a lot of runs because it was really still, it was a lot of calcium. And then we went in with a 3.0 OPN at 40 atmospheres. After imaging, I will show the images. Then we used a Wolverine at 3.5, and then I used 2 Protégé with a very good angiographic and OCT result. Now, why do I combine? Now you'll see it. So here is the rotablation. This is, of course, probably the best way to just make some progress and finish the case. Otherwise, you will just struggle for years with balloons which are rupturing. And then you see with a 1.5 burr, you don't do much of lesion preparation. And that's very important to realize. With rotational atherectomy, very often you create a channel, but you don't really modify the lesion. For the lesion modification, you have to do something else. And in this case, as I said, we used an open NC balloon to crack, and we use a cutting balloon. Now, the open NC balloon will crack the ring and will create some space. The cutting balloon will create the cavities. Let's say we will create the cuts into the tissue, as you can see here, so you can generate luminal gain. And I will show you at the end of this presentation a slide which explains what's the best indicator for luminal gain. How do we tackle a calcium nodule? That's a bit more difficult because IVL and also OPN are not really ideal for calcium nodules. So I think in a calcium nodule, if you can shave it, you should shave it. This is a case we did live for Toby some weeks ago. And you can see here in this caudal view, that's a very tight proximal LAD stenosis, which is so eccentric because it's basically the nodule. And here you see the nodule is there, it's obstructing. And the great thing is the wire or the OC catheter is actually touching the nodule. So this is an ideal situation for me to go with orbital atherectomy first. So here we went with orbital at low and high speed. Then we went in with an OPN. Then we used the Wolverine, so cut and crack again, and then we used 2 protege. And this was the final result. As you can, if you remember the previous picture, the stenosis is gone. And look at the luminal gain we achieved with this method. Fantastic luminal gain, 7 at least. So it was 5.5 MLA, and for most part, it was actually more. We have some cuts, we have some cracks, but this lesion will modify very well, I'm very sure, and the patient felt the difference right on the table. Now, sometimes you have calcium, but you have also these fibrocalcific lesions, like in this case. And in those cases, I think using cutting balloons or maybe scoring balloons sometimes is very important, because otherwise it will be hard to generate lumen. And if you insist with NC balloons, you will just create big dissections, and then you cannot use a drug-coated balloon. So in this lesion, you can see from intravascular imaging, so we see calcium, but we see a lot of fibrosis. So here we used OCT to identify, and then we continued. We used 2.5 and 3.0 cutting balloon, and then I used a 3.0 OPN balloon for additional luminal gain. You could have used a normal NC balloon, or maybe, and one of these high pressure balloons, and then 2 protege to finish up. But look at the lesion. This long lesion in this patient with multiple risk factors for restenosis is completely open. You see also from the caudal view, the stenosis is gone, and the patient has been adequately treated. This is the OCT. You see quite a bit of dissections, but that's actually fine, and this is what we want. Very often, these lesions, if they contain a little bit of calcium, they are actually not at danger for an acute occlusion, and that's because the calcium stops the propagation of the hematoma. Now, if I can conclude with this, I think if the lesion is soft, if the lesion is very soft, or if you have a plaque rupture, I think sometimes even a stent could do a good job, but we will hear Professor Shehab telling something completely different. I'm aware of that. I think if you want to gain lumen, use an NC balloon. Maybe sometimes there's different balloons. I know the grip TT balloon, which is a balloon which is not very aggressive. You can modify these lesions with such balloons, but I think cutting balloons, be careful with cutting balloons if you see this is a soft or acute lesion. If the lesion is fibrotic, then I think the use of cutting balloons and scoring balloons is very, very helpful. If the lesion is fibrocalcific, then yes, cut and crack is the principle, and I use it now for many years. And if the lesion is hard, if you have a ring, then you have to crack the ring with open or IVL. And if you have the nodule, then you have to shave it, if you can, with orbital or a large burr rotational atherectomy. I would just like to show you these 2 slides. Vascular healing, this is very important. And in this population, we had patients treated with sirolimus and treated with paclitaxel. And we had 54 patients with an OCT follow-up. So OCT at baseline, OCT at follow-up. And as you can see here, luminal gain from 4.1 post-PCI to 4.8 at a mean of about 2 months. So we can induce luminal gain. Now, this means in 70% of the patients, we had luminal gain. Now, if you look, this is an example. The luminal gain happens usually where you have the most damage, if you want. And what was also interesting, the most significant predictor of luminal gain was cavity depth. So it was not the arc of the dissection. It was not the presence of a medial or intimal dissection, but it was really the cavity depth. So in one way, I can say that if you create a deep cut into the media, that's where you will probably get the most luminal gain. And this is something which was a bit of surprise for me, and we'll be publishing this soon. But I think you have to do something with these vessels before you expect them to grow. And I will finish now, and I'm open maybe for some questions and a short discussion before we continue. So we have do we have a question from the panel?
Yes, sir, we do have. I have sent you one, and I'm sending you the other. We have received 2 questions.
Okay, so one question is from Dr. Bianca, is what happens if we don't use cutting balloons and only anti-balloon before using DCB? Maybe let's Mohamed, what do you think? Do we always need a cutting balloon or can we get away with an NC balloon? I'll pass this question to you.
And I don't. I mean, one has to be pragmatic. There's no dogma in medicine and practice. You wanted a full and good preparation of the lesion. If the cutting of the non-compliant balloon does the job, then absolutely. This is where imaging comes in to understand what you're doing and how you're affecting the artery. So if the non-compliant balloon does the trick, fine. Cutting balloon can come if you haven't achieved what you want by using the non-compliant balloon. That would be my approach.
I fully agree. I think you can always try an NC balloon. However, I think if you use a big NC balloon, then you have a danger of dissection.
Yeah.
So I think it's always the question of sizing. Now we have a second question. Sorry, Mohamed.
No, I was going to say, I often in cases like this, if I'm going to go not using cutting balloon, I'll go for scoring balloon. The angiosculpt with the metal mesh on top of it, with the nitinol mesh, I think has been really good, and I think it causes much less dissection. But of course, yeah, sizing is the main thing. Your message is very important about and you go down with the size, you go up with the pressure. That's the most important bit.
Thank you so much. And we have a second question. Carlo, are you with us? Abdullah, Professor Shahab, are you with us? We have a question. What's the DAP recommendation after DCB compared to DS? Well, so for me, usually we say 4 weeks in Lucerne. Mohamed, how do you do it?
We're still probably up to 3 months. I think there is no set rule. Everybody's doing what they want right now, and what they feel is right. I think 4 weeks is probably enough. And again, it depends on the lesion that we're treating. If you have a complex long lesion, CTO, and you just used a drug-eluting balloon, stented the CTO and distal drug-eluting balloon, I might prolong it a little bit more. In simpler lesions, 4 weeks is more than enough.
So very good. I think what is also important, and this is a different topic, is the topic of acute management. The topic of long-term management with DAPT is actually not that of importance, because very often, yesterday a patient called, so the doctor of a patient called in and said he never received clopidogrel after the treatment. he was just left with so he was on anticoagulation and used apixaban, and that's it. He never used clopidogrel for 1 month, and nothing happened with us. Without then nothing happens. But I think acutely, very often, what I see sometimes, if we use extensive cutting balloons and long lesions, very often we see thrombus formation on OCT, and you see maybe flow deterioration. So I think we have to be aware that acutely, especially in patients which are not pre-treated, treating them extensively with a cutting balloon and DCB, maybe be a bit more aware of antiplatelet therapy and maybe more heparin or heparin for a few more hours after the procedure. This is something which is important when we don't speak much about it. Mohamed, do you think?
Yeah, I totally agree, because it's just the way the balloons work. Because the dissection will lead to thrombus formation. So if your platelets are not very well inhibited, your anticoagulation is not as effective, thrombus can form. So it is important to make sure. Just because one patient, I do think flow is really the most significant and most important part in how the outcome can be. But if one patient got away without a problem, doesn't mean we could do it for all until we prove that clinically.
Yeah. So I was actually, just my final comment, I just told some months ago, I told Adnan Kastrati that I use now again GP2B3 inhibitors sometimes acutely. And he was like, Florim, it took me so many years to kill the GP2B3 and now you're bringing them back. And I said to him, yes, but with stents, I agree, because with stents, you basically rearrange the morphology. But with DCB, you don't do that. You have a lot of subendothelial tissue exposed to the blood. And that's why I think you need more aggressive antiplatelet therapy.
I still use 2B3 inhibitor on occasion. Absolutely. Absolutely. I thought you were working with me. Yes, no, definitely. We still use it. There are cases where, again, this is kind of, you develop that sense and you know which one you probably need to do, particularly in people who are coming antiplatelet naive. They haven't been on antiplatelet for a long time and the lesion's long and complex. 2B3 inhibitor sometimes does have a role.
Great. So we continue. Let's go to the next talk. We have, I see him online, Dr. Anirban Chaudhry, and he will tell us that in ISR, DCB is not dead yet. Please. Please unmute yourself, Dr. Anirban.
Yeah, can you hear me now?
Yeah, we can hear you, but we see a black screen. Ah, now you have the slides. Fantastic. So please keep it short so we can challenge you with some questions, okay?
Yeah, just let me get into slide presenter. Can you see the first slide?
Yes, we see.
Okay, great. Thank you, and thanks for a fantastic opening. So today I've been asked to speak on no metal on metal precision ISR CTO with DCB, which is essentially what you've just opened up by saying to say that DCB is not dead in ISR. Okay, when we first had our first DES study with zero mace, we thought we have sorted the problem, and these sort of pictures were not that uncommon. But we realized over time, no, there is mace. We just had one study with zero mace, and stent failure isn't easy to treat. And that didn't take us long to realize that. And not surprisingly, when we tried to deal with stent failures, the modality of treatment that we looked into was DCB. So if you look into the multiple studies which have been done with the DCBs, in-stent restenosis was the first one, and still the biggest representative group in which it has been looked into. And this is not entirely inclusive of everything, but these are the number of studies which have been looked into for DCB and ISR, and there's still a lot of studies going on, especially for the newer products which are coming into the market. And everything was going hunky-dory with the ESC presentation of 2014, 2018, which recommended class 1 indication for DCB, especially in bare metal stent restenosis. And that led to a gradual, if I could use the word, expansion of where we can use DCB, as you have pointed out in your first talk. And we have come to a position where we think, okay, if we prepare the vessel or prepare a lesion and it looks good, we can treat it with a DCB to keep the vessel uncaged. Or if we don't get a good enough result, we proceed with stenting. So that's been the direction of travel to a certain extent. Based on that, there's projected massive expansion of DCB therapy around the world. And this is one of those reports. But the spanner in the work was the ESC guidelines last year, which revised what was the preceding guidelines and essentially said that in DES restenosis, which is what we encounter nowadays in real life practice, putting in another layer of metal with the DES is preferred over a DCB. So now let's look into why and how it was done and phrased, and it took into consideration studies between drug-coated balloons with paclitaxel DES, which we don't have anymore. But even in that cohort, there was an efficacy benefit towards the paclitaxel DES. But with regards to everolimus DES, it was very clear that there may be a potential advantage if you put everything together as a mace over drug-coated balloons. But now let's look into what were the references based on which the guidelines were changed. When you look into these references, these are essentially largely meta-analysis. And this is one of that, which took into consideration some of the well-known studies. And what it reported is, compared to especially paclitaxel-eluting stents, if you look at the safety outcomes, there seemed to be a numerical advantage for the balloons. But when it came to the efficacy outcomes, which is TLR, there's clearly in favor of DES. And this is how it was phrased, that there was an efficacy benefit compared to paclitaxel-eluting stents. But then you look into the everolimus-eluting stents, what we found was the efficacy advantage was still again in favor of the stents, but the safety outcomes, which were sort of suggesting in favor of DCBs against the paclitaxel-eluting stents, was no longer there. So there's no safety signal in favor of the DCB compared to the everolimus-eluting stents. And this is how the second part of the guidelines were phrased. But the question is, have we as an interventional community changed our practice to how we approach ISR? And I've been to a few meetings and we have hand polls, etc. And it seems probably marginally we have. So if we don't get a good enough vessel preparation or in ISR, we feel a bit more comfortable and don't feel guilty in putting a second layer of metal. But in general, the approach has remained, if we can do a DCB, treat the ISR with a DCB. That is still the preferred way to approach these patients. And the question is why? Why, as a community, it comes across that we are not really following the altered guidelines. And the reason is we know that a DCB failure is much easier to treat than a stent failure. So if you use DCB, if you look into solution data and a lot of other data, if there's acute vessel closure, or even if you have a TLR in the DCB treated arm, a bit 10% in a year or 15% in 2 years, that is much easier to treat than a stent failure. And that takes us to one of the cases that I'm going to show. The story starts in 2021. We had a 66-year-old lady who presented with an NSTEMI. This was the anatomy, and by patient preference, she went to PCI. And this is, again, important how you prepare a vessel. This was a 275 balloon, which was used to prepare the ostium of the circumflex. And you can see it is slightly constrained. The balloon is more eccentric. So as expected on the outer curve of the circumflex ostium, you have a deep calcium. So you put in a stent, which is 3.5 now, and it has a slightly hazy appearance exactly where you had this constrained appearance in the balloon. And when you pot and you recross, you can clearly see the recoil, which is much more obvious now than it was when the stent was implanted. When you kiss, it tends to go away, that appearance, but then when you finish, you again get back that recoil. So this is typically what we at times see if we haven't been very particular how we prepare a particular lesion. And the story carries on. She goes 2 years and represents in 2023, again with an NSTEMI, and this time with clear lateral changes. And this is the angiogram. So we have a separate ISR in the proximal part of the circumflex and maybe a little bit more obvious in the ostium of the circumflex. And this is what happens. This was a second balloon inflation. The first balloon inflation was probably beyond the stent by mistake, and this has resulted in dissection of the vessel and vessel closure distally in quite a tortuous vessel. So what the operator tries to do is cover the dissection to get flow. Not surprisingly, you find there is propagation of the hematoma because of squeezing it out further distally. Then you have another stent in the tortuous part of the distal part of the circumflex, and the finish of the procedure by treating the ISR with another DES. And again, you can see where the ISR was. You can see there's tissue outside the balloon, and the balloon is slightly constrained in the proximal circumflex. And so the finish the procedure, when you have a vessel closure like that, you're happy to finish it with a TV3 flow. You can see some distal hematoma, but correctly that was left on its own because these do resolve over time on its own. So patient goes home, but then represents in March this year, again with infralateral changes. And now we have an occlusive ISR, and you can see the backfilling from the circumflex, and you can see again a focal tight in-stent restenosis in the distal part of the circumflex, and obviously the proximal 2/3 of the stent is entirely blocked. So this is what it looked like after vessel preparation with 2 and 3 millimeter balloons. So clearly it had a lot of tissue, and because of that, we proceeded to debulk it more. And in this occasion, we used a laser at 60-60 setting and then 80-80 with contrast, and used a total of 20,000 pulses. And that was for the areas where you had a lot of residual tissue, where even after vessel preparation with compliant balloons. And then we prepared it further with a scoring balloon. And what is important to notice is we don't see much tissue between the inflated balloon and the pre-existing stent, which gives us often an indirect marker that if we have managed to debulk it satisfactorily, and very likely we'll have a satisfactory vessel preparation. And this is what it looks like, the angiogram after vessel preparation. When you look into it distally, the vessel is 3 millimeters because of how we prepared it. The old stent at that position was in fact a 2.5 stent, stretched to a 2.7. So we have stretched the stent already to an appropriate size. And proximally it was a 3.5 stent, but we have already stretched it to a 4 millimeter as part of the vessel preparation. And you can see very, very little tissue in majority of the stented segment. So we then proceed with the 315 protege for the distal vessel. We have 3 separate inflations for 30 seconds each, covering the distal half of the stented segment. And then we take a 420 protege, and again, have 3 separate inflations for 30 seconds each to cover the entire length from the ostium of the circumflex to the distal part of the middle part of the circumflex. And this was the final result in this particular patient. So this patient in the proximal, about 24 millimeters, essentially had 2 layers of metal and then had separate stents with degrees of overlap for essentially mid to distal part of the circumflex. So how safe it is? Well, the balloon, the technology of Prodigy has a couple of special features. It has a trifold appearance. The drug is pipetted in between the folds, and it is then wrapped up by a wing-sync technology, which gives it a low crossing profile, which makes it very deliverable. In fact, the most deliverable DCB that I've used. And because the drug is hidden in the folds in a very tightly wrapped manner, it on paper minimizes any drug loss during transit, which helps it to be distinguished from some other DCBs, which is just a coating of a drug on the balloon itself. And there is data. What all we require for satisfactory smooth muscle proliferation is achieve a concentration of 1 microliters, and that is achieved even with the third inflation of the Prodigy, and even with 30-second inflation, we get enough drug elution as part of it. So this is the reason it allows us to potentially, so this is not published. This, I believe, was developed by Bluetech Medical before it was the technology was acquired. But with regards to the clinical study of Prodigy, which is the Pearl study, 40% of the cases involved inflation of the balloon at least twice, if not 3 times. So there is clinical data of it being efficacious despite not having the animal model data, which is not published. So to summarize, what I feel is despite changes in the guidelines of treatment of ISR, there seems to be a preference of the intervention community to avoid metal on metal wherever possible. And for us to achieve that, we should make every effort to identify and correct the causes of ISR so that we can potentially achieve optimal lesion preparation within the ISR segments, which then allows us to avoid a metal on metal wherever possible. And the design of the Prodigy DCB with its excellent deliverability and multiple inflations allows us to often treat long segments of ISR with a lesser number of DCBs, which potentially has financial benefits to the healthcare system. Thank you.
Thank you so much, Dr. Nariman. Very, very good talk. And you gave us some hope back that DCBs can still be used and make sense in secondary stenosis. I have one question. Do you think that imaging can help to decide whether an ISR can be treated with a DCB or a stent? Just a brief statement on what's the role of imaging in guiding you to choose one or the other?
So I typically use imaging for ISR cases when I'm doing ultra-low contrast PCI for ISR in CKD patients. So rather than having an angiographic image of whether the lesion is prepared, I do it by imaging. If that is not a concern, I would image it if I'm not sure of my vessel preparation. So for example, in this particular patient where you have very satisfactory lesion vessel preparation at the end of your preparation, I do not feel that imaging adds. But if I'm not sure, at times imaging tells me whether my vessel preparation is optimal, or I might have to patch a small area with a stent, but the rest I can still DCB.
So the reason I asked that was that I think we have to ask the audience to be a bit more challenging for us. I still don't receive too many questions, but the reason I ask is, I think if you can generate lumen with your lesion preparation, then DCB is a good choice. Sometimes you can't just you try, you cut, you crack, but you still don't generate lumen. And there, I think stent makes sense not for the purpose of having a drug there, but for the purpose of having a scaffold which really gives you lumen. That's what was the reason for me to say imaging or not, but of course you can use that also from angiographic guidance.
Another thing which might help, for example, in similar cases, which is an ISR CTO, which might be acute or subacute rather than a bit chronic, you might have a lot of thrombus. And if you have a lot of thrombus, then the DCB might be limited. But if you see it's mostly smooth muscled, and if you're prepared the lesion enough, you know DCB will do a pretty good job. Yeah, I totally agree with what you said, and that's what I was trying to convey is in ultra low contrast, you assess entirely lumen gain. And if it's a normal patient, if you're not sure, at times it looks worse than what it is inside. And you might not need a stent, though you may not be sure.
Yeah. Thank you
And
so much.
Arfan, sorry, just a quick comment. Thank you. It's a great talk. I mean, obviously, in-stent restenosis is always very difficult to treat because we know everything is caged. You're trying to squeeze everything out, and if you don't get rid of this hard, terrible material, so florin point is very pertinent. If the lumen generator is quite good and the flow is good, using a drug-eluting balloon it can be very effective. On the other hand, if there's not enough lumen, then this is where you need to get rid of the tissue. And I think this is what you showed the case about laser. I do use laser in these cases frequently to soften that tissue and allow you to squeeze it out and get rid of it. So laser, I know it's not available everywhere, but it is one of the way to kind of get rid of this the in-stent tissue that's formed over the.
Okay, so we have one question from the audience. Thank you, great talk. Thoughts on use of laser versus rotational atherectomy for lumen preparation in at least two layer of ISR. So maybe a brief comment from you, Monet, and
Yeah, I've just mentioned, I think laser is much more effective in here because it modifies the tissue, whether inside the stent or even outside the stent. Rotablation, unless there's calcium, unless severe, like heavy fibrosis, might not be as effective. On occasion you have to use it, but I found laser much more helpful and much more effective in such cases.
Yeah, I totally agree. I mean, unless you have calcification in the superficial part of your ISR, which causes luminal obstruction, rota may not have much to offer, especially if it's a smooth muscle proliferation or if the problem is beyond the stent. In both situations, laser, often is the answer.
Yeah, and then we have one question, but I think about the solution de novo, and this is a long question about the statistics. I think we have to wait for the publication and then see to discuss it. So maybe we proceed with the next talk. We have, as the next talk, we have Dr. Rupesh Singhal, and he will tell us which patient to choose. So patient selection for drug-coated balloon therapy treatment. Please.
So I'm really honored to be a part of this meeting. I believe you can see my slides.
Yes, very fancy slide, a very fancy entry. So let's.
Yeah. So I think the PowerPoint did that for me, the designer section. So I have multiple, as pointed out with Dr. Chaudhary, multiple factors are associated with stent failures, and often we see a combination of these factors in a single patient, which lead to clinical scenarios where stents may be undesirable or unsuitable. Drug-coated balloons then often become a tool for local drug delivery in such patients without actually leaving a permanent implant back. So this concept of leaving nothing behind is gaining popularity as we are using more and more DCBs, as we are getting more confident, as more like we are doing more check angiographies of this patient and seeing good outcomes. Our confidence of the therapy is increasing. And currently, DCBs are being used for in-stent restenosis. This is the most studied and the approved guideline. It's being used for small vessel disease. It's being used for diffuse disease. Diffuse disease is something which is really very common in at least in the Indian patients. Tortuous anatomies, high bleeding risk patients, bifurcation disease, and in few selected patients with ACS and CTOs as well. So let's look at them one by one. And in-stent restenosis, still around 5 to 10% of our PCIs are being done for treatment of in-stent restenosis. And as pointed out, DCB will, give a more uniform drug delivery. It avoids the additional metal layer. And as rightly pointed out by Dr. Chaudhary, that this is the main concern. Though despite that, we know that DCB is non-inferior for treatment of BMS ISR, and the treatment, the data for DES ISR is slightly more tricky to interpret. So it's DCB is out there for treatment of BMS restenosis. It's BMS restenosis, we rarely see this nowadays. This restenosis is again very tricky, as explained in detail by Dr. Chaudhary, and I'll not go into the slide again. He also addressed this meta-analysis, which was of 10 studies. And I'll just would like to spend some time on this chart. So what I would like to point out is like BMS ISR is obviously easier to treat, and DES ISR, whether treated with a DES or a DCB, has not so good outcomes. So it's a bad disease to treat. And that's probably, as pointed out, the rational or our fear of putting in an additional metal layer. So with the studies, like in my restenosis patients, what I would do is patients having, multiple layer of stents, definitely a DCB. If there is a significant side branch which can get jailed behind, then if I put in a second layer, I would prefer a DCB. If there is some focal disease and if imaging does not, has adequate luminal gain, I would want to go with a DCB. So this is one particular case, two long stents put right away from the ostium of the LAD till almost the distal part. This was done somewhere outside, and he developed this restenosis within around 8 months of index procedure. So I did an imaging for this patient. I believe it was undersized, ventilated with a cutting balloon, high pressure NCs, 2 protage, and this was the final result. Please, I would like to point out, like, it's a big diagonal. I did not definitely wanted to jail it behind a second layer of stents. There is already a plaque shift that we can see with a DCB. If this vessel diagonal was occluded with a DES, I would have, it would have taken some work out of me. So coming to small vessel disease, size matters. We know small vessel disease is associated with higher restenosis rate. There are stent delivery challenges. There is usually no optimal landing zone, higher thrombosis risk, and we know these patients have much higher TLR. So if we look at stent failure data in small vessel disease, we see that the rates of restenosis and lesion TLR rates are almost much higher as compared to or expected to stents. Even if you look at the more recent data, so this was presented in PCR in 2022, even with contemporary or the more recent generation of stents, still in vessels less than 2.75 millimeters, the lesion failure rates are significantly high. So how does DCB fare in this small vessel disease? Now, there are a lot of data is there. The more recent trials, the Basket Small, Restore, and Piccoloto have established DCB as non-inferior treatment to DES in small vessel disease. What about the length? Again, we know that diameter matters, so does the length. Long diffuse stents have worse outcomes. So stent failure with long lesions is known. We have data to support it, and we have seen it in our clinical practice as well. Stents associated more than 40 millimeters were associated with almost a double restenosis rate, double stent thrombosis rate, and TLR rates as compared to when lengths less than 20 millimeters of stent. So again, if you do a DCB versus stents in long lesions, the more recent sequent plays, long ball, basket small, again established DCB as non-inferior to DES while preserving the vessel architecture. Again, we are not jailing 50 millimeters and 60 millimeters of vessel behind a metal cage. So this is a patient which I did 1.5 years back. She is a 60-year obese obstructive sleep apnea patient, surgical turn down, small vessels, diffusely disease, no optimal landing zone. There's a bifurcation in circ and the major OM. There is a bifurcation in LAD in diagonal and small vessel diameter bifurcations. We can see a lot of calcium there. So I plan to do a DCB only PCI for this case. The lesion was not opening up with the cutting balloons, and I really went up to a higher pressure. This, I believe, was a 2.5 millimeter cutting balloon, and I went up to 20 atmospheres. Unfortunately, I landed up with a major flap, which was not acceptable me to that point. So I had to treat that with a Yukon stent at that point of time. The L6 and the major OMs were then treated with DCB. This was the final result. There is some dissection in the diagonal, not a very good angiographic outcome, but she's been on follow-up for last 1.5 years, no angina, doing well, and she's doing good. What about the tortuosity? So this, again, this concept of vasomation or endothelial dysfunction due to metal caging is again being studied a lot. So it was evaluated where vasoconstriction after acetylcholine infusion was studied, and it was found that this vasoconstriction was less pronounced in patients with DCB, and So this is where the concept of bioadapters is also coming in. So vasomotion, the natural coronary artery shape, the natural anatomy needs to be respected. And when we try to bend nature to our demands, we are faced with higher TLR rates. So this is a study published in 2021, which looks at BMS first and second generation discs in tortuous versus non-tortuous vessels. And you can see almost 10% higher failure rates in patients with tortuous vessels. So this again is a very recent case. She presented with a non-escalation MI, non-obstructive disease in the left system. So this is her RCA. Entire roller coaster bend in the RCA, and again I planned it with, I mean, there was no doubts in my mind that I would just want to do a DCB and come out. So this is the result after 2 proteage. There is some dissection flap in the distal PDA, which was acceptable. Unfortunately, this patient developed local site complication, and I had to, give some heparin reversal. I mean, it reinforced my belief in DCB. Imagine giving a protamine after putting in small stents in tortuous anatomies. So luckily the patient did well and she was discharged 2 days later. In patients with high bleeding risk debut trial, patients, often we see patients being referred from other surgical domains. They have been patients come up for oncosurgery or other major surgeries and then diagnosed with severe coronary artery disease, which needs to be addressed before doing surgeries like major oncosurgeries. So again, DCB is a very good option in these patients, and rather than a BMS, which was at one point being considered for patients who are very high bleeding risk or who will require a surgery in very near future. And DCB is associated with a much lower lesion failure rate as compared to BMS in these patients. Bifurcation PCI. This again is an area where I personally use DCB as lost. We all know provisional is better. So with the same thought that provisional stenting is better, why not extrapolate and give that side branch an additional benefit of drug-coated balloon? Obviously, that concept of doing entire bifurcation with both side branch and main vessel with a drug-coated balloon is being investigated. And but yes, when I started doing DCBs for bifurcation, it was initially for side branch, and there have been enough trials for this depth side, hyper, and biolux, and all of them have sort of are promoting or established DCB for the side branch. There are studies which are still evaluating the hybrid approach when you stent the main vessel and you just do a DCB for the side branch. And we will see how these outcomes fare in the future. So this is a 72-year-old gentleman, acute anterolateral wall MI, some calcific disease in the LAD. If you can see a very faint diagonal, which was responsible for his events. The circ was flowing. This is after the initial POBA and wiring. There is some disease in the LAD. This is around, I think, 11 p.m. in the night, 78-year-old gentlemen. I just decided that I will want to dilate the diagonal with a drug-coated balloon and come out. Obviously, I secured the LAD, but did nothing to it, just kept my wire in, and this was the result after the drug-coated balloon. Again, very good flow. After removing the wire, I waited in the lab. I noticed the flap. I waited in the lab for some time, but I was very confident leaving this flap there, and the patient did well. So we all know this thought process that stents sometimes fail, and could we do better? Can we leave that landing zone for a bypass graft? Can we respect the natural coronary anatomy? If the patient comes back, what will I do? So all these questions go up in our mind, and DCB sort of offers a very nice way out. Again, for proper implementation, proper approach to drug-coated balloon must be respected. Dr. Floram did a wonderful, presented a wonderful talk on how we optimize the lesion and prepare the lesion before doing a DCB. And again, I would like to say that it's the synergy between DES and DEB. Ultimately, both of them will work together to give better results. Thank you.
Thank you very much. Very nice talk. I don't see any online questions. Do we have any questions from the panel or any disagreement? We all agree way too much. Let's disagree a little bit.
Well,
Do we have?
you can't disagree, because in a way that what Dr. Singhal kind of presented, you could use it anywhere. I mean, using drug-eluting balloon, everybody trying to relay this message, it will involve kind of having that shift in our mindset. We're always being trained about having that proper cosmetic, beautiful appearance of the stent. And in the drug-eluting balloon, it's not going to be the same. It's the functionality, it's the flow that will keep the artery open, and it's not going to be perfect angiographically. And this is where you start learning. That's leaving some dissection, which usually what allows the drug to go in, and kind of as long as the flow is good, I don't think there should be any issue. So changing that mindset of you have to have that cosmetic, beautiful appearance has to be the first thing to kind of, if you want to use drug-eluting balloon.
I have one provocative question, and we can discuss it briefly in the panel. Are stents nowadays just a bailout therapy for patients we cannot treat with DCB? Be binary, Mohamed. Yes, no?
No,
Not yet.
not yet.
Not yet. Okay.
Not yet.
What do you think, Dr. Singhal?
Not yet. Again, like if it's a proximal LED, straightforward lesion, 3.5 millimeters, I would still stent it.
Okay. Dr. Anirban, what do you think? Can you buy in?
Yeah, I agree with both Mohammed and Rupesh. I don't think we are there yet.
Okay.
We have to be a little careful. We're drug-eluting stent, if you do it well, size it correctly, execute the procedure well, they still have a very, very good result. I take on board the recent presentation. Everybody's excited, but we have to wait for the paper to see, because to set the margin, the non-inferiority margin at 50%, that's even with 2.5% event rate in the drug-eluting stent, you're going to have some. The drug-eluting balloon will come out non-inferior. The experience over the years from a lot of people who've been using, and I have been using drug-eluting balloon for a long time, but similarly, I'm going to be more provocative here and say there are cases where even normal POPA, normal balloon would do the same. I'd love to see a study comparing the two. I know there's some publication here that showed that POPA is still not as good, and the Swedish registry, I think, showed equivalence. I think if you achieve a good lumen, good flow, there are cases where you don't have to use a drug-eluting balloon. But of course, I don't think this study will be done, because it probably will kill that industry.
Well,
but I think it's. I'd love to have a study comparing drug-eluting stent, drug-eluting balloon, and POPA in certain cases.
Well, I have tried some patients, and to be honest with you, so I tried a CTO just with POBA, opened the CTO, just POBA, brought the patient back, and then everything looked great, but the CTO had a restenosis again. Then I treated it, and then it was fine. So I think what we have to discuss is, or to detect is, where is it, if it's biologically active, you have to do something about it. If it's biologically active,
CTO is probably the top of, the most complex out of everything, and maybe it's not the place. I have been using POBA for a long, long time without drug-eluting balloon in distal LED, smaller vessels, and if the flow is good, particularly currently with good dual antiplatelet therapy, good statin, good secondary prevention, we might be surprised that the outcome might not be as bad.
I agree with Professor Ingrid. Like, we see a lot of diffuse disease. I mean, it's very common in our continent, diabetic diffuse disease. And we have before DEB was very common. We were doing just POBA for distal LEDs and mid LEDs and leaving them, and they did well.
So I have one question which we have here. Does DCB flow limiting dissections require a DES of the same drug, or is any molecule okay, or should we even use a BMS? Professor Shahab.
Why you have a flow limiting? Need to know the reason for that. If it's, you caused it, then you need to correct it by using a specialized, I think, balloon. We have cutting balloon. We can make that, small dissection, organized dissection, and then we can, we can go with a DCB at the end. I will not use the stent unless I really I do all my best. Yani.
Yes, but if you have to use a stent, the question is, if you have used a sirolimus eluting balloon, should we now go with a sirolimus eluting stent? Or if you have used the paclitaxel coated balloon, should
Doesn't
we?
matter. Doesn't matter. Doesn't matter.
That doesn't matter. I think I fully agree. Is everyone agreeing that, you know, mixing the drugs is probably not a problem?
I don't think it's a problem. I know that there is some work done to produce drug-eluting balloon with both drugs on.
Okay.
And I don't think it won't be long before we have a balloon that has sirolimus and paclitaxel. So I don't think intuitively, because they're two completely different drugs, two completely pharmacology, etc. Sometimes I think with the amount that we have on the balloons and the stent is probably not a major problem.
Okay. Now let's
on this
continue.
on this debate, one little thing is, you know, what we were deciding on stents and DCB. I think a good size vessel with a good size DES done properly is very hard to beat. But if you do a moderate job with the DES, you'll be better off doing a moderate job with the DCB.
Yeah, I mean, to add to that, I think our biggest problem has been the undersizing of stents and under preparation of the lesion. The stent currently are fantastic, really perform very well. Not every undersized or under expanded stent will cause a problem. However, every time you have a problem with the stent is almost invariably undersized or under expanded. So imaging comes in here very helpful to do the procedure well. So yeah, you can't beat a very good angioplasty with drug-eluting balloon so far, with drug-eluting stent so far.
I think we need the Sparks trial to show that, especially in complex lesions. That's what I think. You know, even in a diabetic patient, implanting 80 millimeter of stent, you can implant perfectly, but the likelihood that it will fail is still quite significant.
Sure. Yeah.
But I think in a short stent, non-diabetic 4/18, to beat that with a DCB, very hard. Even at 5 years, you might lose. So I think this is the dilemma we have.
I was going to ask, do we still have bare metal stents?
No.
No.
Only for renal arteries.
Yeah, no, because I think that's even in renal artery I use drug-eluting stent, but yeah, I don't think we had bare metal stent anymore.
Yeah.
Maybe peripheral, but
Okay, so now let's continue because we are a bit late in time. So the next talk is my friend from Newcastle, Dr. Mohamed Egret, and he will be speaking about DCB in situ and calcified lesions. So I hope you will show DCB in a situ with a lot of calcium.
I will. Right, let me share my slide. Oops. There you go. Can you see my slides?
Yes, we can.
Okay, fantastic. Let me just start by right. So, I mean, some of the subject has been covered on how the drug-eluting balloon work and the basics. Let me just say, I'm going to talk. This is a kind of a large subject about CTO and calcium in drug-eluting balloon. However, these are my conflict of interest. I'll talk about DCB and CTO and calcium, then, and which balloon to choose, and then show a couple cases in there. We know that this is how the pulmonary stenosis used to happen. You have the phenomenon, the pathophysiology, and the time course. Elastic recall happens immediately, negative remodeling within 1 to 6 months, and then, of course, new intima formation after that. So how do you tackle this is quite the important bit. And we know that the standard of care remains to be drug-eluting stent. We've been doing it for many years. Acute closure by covering the dissection, achieving excellent angiographic result, and the restenosis and stent thrombosis compared with bare metal stent has been much improved. In the CTO setting, we know there's always long segment and long stent needed for these cases. And when you do long stent, we know that the outcome is not as good. Because malapposition and stopping the vessel from remodeling, etc. So this is quite important in CTOs. And we know that when you are the predictors of restenosis, my previous colleague who presented showed this, but I'm just focusing on this here. The lesion-related risk factor are small target vessels, you have osseal lesion, longer stented area, complex morphology, and the stenosis more than 20 millimeter length. So, of course, these are quite important in addition to the other factors, of course. And we know that the longer stents, we have a poor outcome. This is one of the grand DES registry, just as one example. You could see almost double the rate when you have longer stents, and this is more than 40 millimeter. So this is where a drug-eluting balloon has come, because it is fast, homogeneous drug delivery into the vessel wall, and the medication that was chosen, highly lipophilic, it kind of gets to the vessel wall and affect it and stop the restenosis from happening. And of course, that in mind, so if we are going to prevent the elastic recall, it's the stent. Negative remodeling might not be always just by stent, because you could do the drug-eluting balloon and achieve a good flow in the lesion, which will allow you which will allow the negative remodeling to reverse and the artery to kind of become the normal size. And of course, with the medication that we give, paclitaxel or sirolimus, you stop the new intimal formation. So of course, what's the advantage in the DCB? As you know, it's less metal, of course, potentially higher trackability in complex anatomy, less fear to impair side branches. This all has been covered, but it's always important to re-emphasize it so everybody knows why we're thinking this way. It's interesting option, of course, in lung disease segment and distal to the CTO. You open the CTO, you put a stent, and you treat the rest of the disease with drug-eluting balloon. So you reduce the length of the stent, and in turn, you reduce the long-term effect. It is, of course, an interesting option for in-stent restenosis and occlusion, and we've touched on this with the previous talk, and potentially less need for stronger antithrombotic regimen. This was asked before. How long do you continue the dual antiplatelet therapy and so on? The disadvantages, of course, it has to have the proper pre-dilatation and preparation. There's no question about this. And of course, is it, in terms of talking CTOs, is it suitable for extra black technique? This is something remains to be seen. If you're in subintimal space and extra black, can you deploy the? Of course, there are more and more data coming along, and we're finding out it can be okay, but we still don't know. You have sometimes to be thinking about aneurysm formation and so on. There's still some long-term equipoise with the data, and as I said before in my comment, it's a major mindset change for current interventional cardiologists. We are used to see this beautiful appearance of the artery with the stent. So we have to start thinking it doesn't have to be beautiful; it has to be functional and flowing very nicely. So, and of course, in terms of the CTO itself, you have two reasons. A lot of the time, if you're not successful, you do what's called an investment procedure, where you open the artery, but you don't stent it because you haven't connected the true to true. So you dilate the extra black and the black, and that's called investment, to come back later. And that's a rationale maybe to use a drug-eluting balloon to stop the proliferation, stop the occlusion again. The second one is a lot of cases where you have CTO, the distal vessel is negatively remodeled, it's small. And when you open it up, if you are going to size it acutely, you put a stent in according to the vessel that's negatively remodeled. When it opens up after a while, you could see that it could dilate and you have a malopposition. And malopposition of the stent is probably a very significant risk factor for stent restenosis, in-stent restenosis and occlusion and thrombosis. So these are really rationale to try to think about drug-eluting balloon in CTOs. And of course, there has been not too many studies. They're all quite small, but this is what's been shown on the longer-term outcomes. Some that there was no difference between drug-eluting balloon and de novo CTO, and that's of course over to in terms of 2 years follow-up. These are very small studies. Some of them are 24 drug-eluting balloon, 41 consecutive patients. There are some couple cases or a couple study, 34 cases. So they are small, and we're not there yet. So a word of caution, but at least it shows us that it is safe if you choose the right patient and you leave the right case without a stent. And of course, now at this stage, the past used to be like you put stent implantation, the beautiful angiographic appearance, full metal jacket, and the vessel is permanently caged. The physiologic vasomotor activity is changed, and of course, there's no compliance. So the future probably would be preserved vasomotion by the drug-eluting balloon, all positive remodeling of the vessel, so you're not worried about the size of the stent and malopposition, and you avoid the metallic scaffold complication, of course, and you leave the options open for future procedure if needed. So summary to say that about the CTO, DCB offer valuable alternative at this stage. I still think the hybrid approach currently is probably the reasonable strategy, where you open the CTO, you stent that area, because the scaffolding and the complexity of the CTO will make it better. And then you treat the distal part by using drug-eluting balloon, because often we'll find a long segment of disease to avoid metal jacket, a full metal jacket, and what the disadvantage I mentioned before, drug-eluting balloon becomes good. Now, what about calcified coronary lesions? You know that calcium, and I think it's been touched on by Florim and the other colleagues. Calcium is really difficult to treat. And we know that nowadays almost 1/3 of the cases we treat has calcium. It reduces vessel compliance, hinders stent expansion, and impaired drug uptake, etc. And there's a poorer outcome. I don't need to be telling you this because everybody knows it. And this is just kind of one publication to show you the difference if you have severe calcification in the artery, despite treating it and modifying it. So where's the advantage of, or the potential disadvantage for the drug-eluting balloon? It's more difficult to assess the adequate lesion preparation. And I'm yet to be convinced or to know how, because I always thought the drug works by kind of diffusing into the vessel. If you have lots of calcium, even if you crack the calcium, there's not much drug on the balloon to get through these cracks to give you the same level as if there's no calcium. Nonetheless, it's been used, and I think there has been a recent study, but I think it was presented in TCT, to show reasonable outcome. But nonetheless, it's still something we need to be thinking about. It is unlikely to achieve equivalent acute luminal gain, of course, against stent. And as I mentioned, the compromised drug transfer, we don't know. Does the calcium have an effect where the drug goes? Because it will not be able to diffuse into the wall because it's lipophilic. The potential advantage, of course, they avoid the risk of underexpansion, which happens a lot with calcium. Of course, the use of in diffuse disease with poor landing zone of the stent, angulated lesion, and they preserve the vasomotion that's already impaired with calcium. You don't want to impair it more by putting a stent encasing that artery. And of course, perhaps potentially safer for early discontinuation of dual antiplatelet therapy. So there is some advantage. If you are going to do it in calcified artery, I would image. Of course, this is not always possible in calcified artery. There's something used to be called the Washington test. You try to put the IVUS down. If it doesn't go, you know that you need calcium modification. But nonetheless, you have to try. If not, you modify the calcium, cutting, scoring, atherectomy, IVL, whichever way you want, or laser, anything you want. And then you prepare the lesion by 1:1 to know that you are the lesion is prepared, and you know that the stenosis is less than 30% and no major flow limiting dissection. And then you deliver the drug-eluting balloon 1:1 size. So that covers the whole lesion and the margin, i.e. a little longer than the lesion to allow you to this. And of course, if the bailout standing remains an option with high-grade dissection and inadequate results. So we have to kind of be pragmatic when we're working with these cases. So there's some evidence for DCB in calcified lesion. This is a meta-analysis of 5 observational study. It's not a huge thing, and there was no difference between the two. Again, there has been a recent publication or a presentation, and I'm sure the paper will be published soon. Data is coming, and we are learning more and more. And I just always try to understand the mechanism. I know that the drug has to go to the wall to affect it. So how does it work in calcium? That's what I still need to be convinced of that. And of course, this is the same thing. So which DCP? Of course, you've heard this. There are lots of drugs on the market, and of course, we started from first generation with the liberamide, and then the different excipient and so on. And we have now into the 3rd generation. And as I mentioned before, I am aware of some work being done to have both medication on board on the balloon. I'm not going to bore you with each one of them and what they work. Most people know this. So is there currently a DCB that offers easy deliverability and protected drug, reduced washout, and increased number? Dr. Anirban has mentioned this, and it's protege balloon up to 3 inflations. So economically, particularly with CTO in particular, because always invariably is a very long lesion, instead of multiple balloons, which are costly, one balloon could offer you the same with 3 inflation. And you've seen this, how this is done. I'm not going to dwell on this, but we know that despite the 3 inflation, you still get, even with the 3rd inflation, you still get the same level or the same effective level of the drug. So it's not something and that's been proven and shown. So that's quite important here. This is a case that was published with somebody using a pre-PCI, and Florim showed a fantastic case at the beginning. I don't want to repeat this, but you can see the calcium. Again, IVL used, scoring balloon used, and then drug-eluting balloon, and come back for follow-up later and the lumen has become better, and even the healing has progressed, and they did not need to use a stent. This is a case we've done in here. Oh, it's not working now. Okay. So this was a case, you could see the calcium in the proximal LAD short, and the flow in the LAD wasn't great. We ended up rotablating this. It was subtotally occluded, and I won't bore you with the result. This was a drug-eluting balloon. The outcome at the end was very good. TIMI3 flow, no major dissection, and lady comes back for follow-up, and here we are. The art is still good and still patent without any issue. And this was a pressure wire because she was symptomatic, and the pressure wire was negative, and there was another lesion in the RCA that was treated. The point is, using drug-eluting balloon did work, and this was calcium. But we were mentioning this big artery, good flow. I think that's probably an area where you'd be comfortable just doing a drug-eluting balloon. Here's the cases of CTOs. I think these are the important one here. This was a case of RCA CTO, female 3-vessel disease. The RCA was treated, opened up, and you'll see how much disease in the RCA. Distally, diffuse disease, and of course we stented this area, but do you go and stent the whole thing and then become a metal mesh all the way, and metal cage basically? And we know the longer the stent, even though appearance and geographically would look good, the longer term outcome is not very good. So the choice was no. Proximally, we had some dissection, so we stented the proximal rod and treated the rest with drug-eluting balloon, and this is how it was left. And I think this is very, very good. The flow, again, to my mind, is the most important determinant of the long-term outcome, particularly at the exit of the stent. And here you see very nice flow, comes back for follow-up, and fantastic, the artery is open. Here's another case with high bleeding risk patient, 76 email, ex-smoker, hypertension, effort angina, ejection fraction is 35%, and this was her. You could see how terrible these arteries are, really subtotal occluded LAD, or totally occluded LAD rather, with severe disease in the circumflex. And again, I'll just show you how we open the artery. This is the right coronary artery. It's reasonable with some cross-filling to the LAD, as you could see. The LAD was open, but because of the nature of that disease, we ended up using pre-dilating and paclitaxel at that stage with this artery and the LAD as well as the diagonal, and good immediate angiographic outcome. Here it is. Yes, it's not perfect. Nonetheless, as we were talking about the negative remodeling, you put any size stent in here, it looks very small for stenting, but you know, if you're starting from a 4.0 vessel proximal 5.0 probably, it's not going to be as small. It will grow, and this is all negative remodeling, so you have to be careful. So drug-eluting balloon here comes very, very helpful. And she comes back with follow-up, and here we are. The LAD is open and starting to grow and looking better. And I think that was the right decision to do, not to put any. And her LV has improved from 35 to 50%. So drug-eluting balloon in here, long diffuse segment of disease. We did not need any stent. And the final case here, just quickly. This was another case, 76 ex-smoker, dyslipidemia, effort angina, again occluded RCA. We open it up by dissection re-entry. Here's a knuckle wire technique, and we open it up and re-enter. And this was an investment procedure because we could not re-enter. In fact, actually, it was like a star technique. You could see the artery is completely dissected. And I debated, do we put a drug-eluting balloon here or not, as I mentioned before, because I don't know in the subintimal space or extra black. However, I did, and this lady comes back, or man, 8 weeks later, and this is the artery. So that shows you, if I would have gone with stent, probably would have been okay, but I don't know. This now, the artery is open, wide open, TIMI3 flow, probably nothing needs to be done unless symptoms develop because the patient was completely asymptomatic. Bottom line is we can do it, and we can use the drug-eluting balloon in long segment of CTO with good outcome. I think I'll skip this one here. So really, in clinical evidence, there's limited data, of course, some publication or some presentation recent. Combination therapy, I think, remain with CTO probably important, hybrid approach until we have more data. And I know there is a study going on in Holland right now looking at this. Reduced stent length will have a very good long-term outcome. And the scaffolding property probably necessary for some cases, particularly in the in the CTO itself. And the natural vessel enlargement, if we have used a CTO, a drug-eluting balloon, as I've shown you, probably will be a very good thing on the long term. Quickly take-home message. It inhibits the excessive hyperplasia, abscess metallic scaffold, promotion of positive remodeling, and preserve motion, and it's really all good. So DCB are here to stay. I don't think they're going to go anywhere, and we're getting more and more data. Optimal lesion preparation, and this is the message I want for everyone. A drug-eluting balloon is a delivery tool. You have to prepare your vessel well, you have to prepare your lesion well, and then you deliver the drug with the drug-eluting balloon. Full metal jacket should no longer be considered a solution. I think it's much better with hybrid approach, and we have to change our mindset to it's not a cosmetic treatment, it's a functional treatment. And with this, I will say thank you, and happy to take any comment or any questions. I'll stop sharing this.
Thank you so much for your very nice talk, great cases. Do we have any questions or comments from the panel?
Mohammed, great. So what sort of CTOs, you are worried if you put a DCB?
It's not about worried. I mean, I don't think when you spend 2 hours trying to open an artery and the artery looks like sometimes like a dog's dinner after you dissected and re-entered and did a lot of things. I think that because of how we've been seeing these all the time, we still use a drug-eluting stent. When I am able to go through the occlusion quick and there's not much dissection, the artery is not as destroyed, because I always, when we do dissection re-entry, almost like I call it the Vietnam approach, you destroy to rebuild it. So the cases where there's not, the artery is not as bad, you might consider drug-eluting balloon. We still haven't got to that stage, at least for me currently. The area of occlusion and the area of severe, or where the artery was occluded with lots of dissection, I still stent it, but I use a lot of drug-eluting balloon DCB. I'd be interested to see if anybody has a different approach and started using more drug-eluting balloon.
I have a question for the panel, because this has been pointed out in 2 speakers about the inflation at 3 times and still achieving the therapeutic drug levels. So if you feel like if you are going to do it at one spot after the first inflation, that the drug levels might be too high, maybe too much of remodeling positive gain, ectasias. What's your take on that?
I missed. Can you repeat the question? Sorry, what's the question?
So we see that even after the 3 inflations, the drug level is still therapeutic, right? It's enough to inhibit the smooth muscle cells. So is the inflation, like the drug level after the first inflation, too high? Do you think it can cause some problems, maybe ectasia or something like that, as we saw with Taxus? The paclitaxel stents.
Maybe I can take this
go
question. So okay, there is some hypothesis of people who just claim things because they project the past into the future. Now, in reality, and I can say this because we use quite a bit of imaging. So what I don't see is aneurysm formation with DCB. I don't know if I miss it, but we bring so many patients back after short, after long term, and we do in so many patients OCTs. I don't see that signal of aneurysm formation. Even in patients where I would expect it treated with cutting balloon and paclitaxel, I don't see that signal. So I think this fear that we induce aneurysms with the drugs is not there, which has led me to do following. And this is something we can discuss. So I use the protege 3 times, but in the same lead, because the reason is, as Mohammed was rightly stating, I think it's functional treatment. But it's a progressive disease. So I think the more lumen we gain, the better the long-term outcome. So that's why I think we have a greater chance of having lumen.
Sorry, we're having a lot of echo.
I don't know why. Do we hear now?
Still a
Still
problem. Some background, yes.
Okay, that's probably better. No, it's not. Yeah,
Maybe
anyway.
everyone else puts the mics on mute and only one speaks. Maybe we should do this. Okay, now
We
it's
still
much
have-
better.
Yeah, okay. There's
it
a bit
works.
of echo, but that's better.
Okay, so
Okay.
I think what I was saying was that I use the balloon 3 times in the same lesion because I haven't seen a signal of aneurysm formation so far, and I think yes, it's a functional treatment, but it's a progressive disease. So if we gave patients more lumen, the hypothesis that would be that we will give them more freedom of events for the future.
And also, sorry, don't forget that the level of drug that's been tested, that it's safe and it's been done for a long time before it's gone on the balloon. So there's no issue in giving too much drug into the wall. Now, there has been some reports about a little bit of aneurysmal dilatation or aneurysm formation after some drug-eluting balloon, but we haven't seen it kind of clinically that significant. I don't know if the others have. Abdullah, I've done a lot of drug-eluting balloon. I don't think aneurysm is something
I get
that
it
you worry
with DS. I used to get it with DS, but not with DCB.
Yeah.
Yeah, that's true. I saw that. So I think, but let's now maybe just one question. So who of you inflates the protege 3 times? Who of you? So Abdullah, BC, and who else? Please make yourself.
I
Carlo,
do as
you.
well.
Okay. And who of you uses it 3 times in the same week?
I mean, the time I use it 3 times, it's if the long lesion, that's the whole thing. But if it's not, I usually probably inflate it twice in this, if it is the same length of the lesion, to allow it to maybe 60 seconds or 90 seconds. But if it's a long lesion, I'm trying to use one balloon, then I'll do it 30, 30, 30.
And so again, like an extension to the discussion that is happening, do you think giving a nice prolonged 90-second inflation versus doing 2 inflations, which works better? Do you think it will make a difference, or it does not really make a difference?
Well,
Well, we don't know.
they have a study on with protege itself, which exactly answers that. So if you inflate it to the same place, the dose increment is very, very marginal. I guess because you lose something as a part of your erosion. But at times we can't keep it up for 90 seconds. When you can't keep it up for 90 seconds, you inflate it multiple times in the same lesion. But going by that argument, in the more difficult ISRs, where you probably have very little concern of aneurysm formation because of the amount of tissue, I do keep it up for more than a minute at times, because that's where the maximum elution happens. So in difficult lesions, that's what I do.
I've seen a graph of how the drug elutes quickly from the balloon, and obviously it's almost like a spike and then slowly comes down. So each balloon is a little different pharmacodynamic and how it works, but yes, it's a spikes up and slowly goes down. I've got no issue inflating it in twice in the same lesion, because that gives you all the drug you need.
Okay.
And it is safe. It's been tested.
Yeah. Okay, so I think let's continue. Now we'll have the Dr. Carlo Brigori from Italy, and he will be speaking about DCB for de novo lesions. What's new? Please, Carlo. Nice to have you here.
Hi, could you hear me? Hello?
Yes.
Yeah, thank you for the invitation. I'd like to activate the video. No, it was stopped by the organizer. Can I have the video? Can you see my slide?
No.
Now?
I think it's coming. Wait.
Can you see the slide?
You can see your screen, I think. So now go to the PowerPoint.
Okay, thank you. Now, can you see the slide?
Yes, we can.
Okay, thank you. So my talk will be on the novel lesions. So what news about that? We have already speak about the problem of DES and long-term outcome. We have at least 2% year event rate related to the stents. So this is why the concept of nothing left behind is important. So we don't want to have metal in the coronary artery in order to prevent the events, also a long-term outcome. What we know, according to the new trial presented at TCT some weeks ago, first we can discuss about safety of the strategy of PCI with drug-coated balloons, so without any metal. So this comes from the solution de novo trial, which has been presented by Christian Spalding at TCT, which is the one-year results of the PCI with the sirolimus-eluting balloon versus systematic stent implantation in de novo coronary lesions. In this trial, they utilized the solution, which is a sirolimus-eluting balloon, which is a dedicated technology. So the trial included de novo patient with de novo lesions. The important of this trial is in the time of randomization. So the patients were randomized before, at the beginning, before the procedure, not after predilatation or lesion preparation. So this is like a strategy, a different strategy. So we have from one side a DCB strategy with solution DCB, and on the other side we have a conventional drug-eluting stent strategy. And the primary endpoint was the target vessel failure at 1 year, which included cardiac death, target vessel myocardial infarction, and clinical driven target vessel revascularization. So the patient with the de novo lesions, the only exclusion criteria angiographic were left main disease, chronic total occlusion, lesion in the graft, both saphenous and arterial graft, and of course in stent-raised stenosis. The vessel diameter should be more than 2 millimeters up to 5 millimeters, no limitation on number of lesions treated, and also STEMI patient and non-STEMI patient were excluded. The strategy of drug-eluting balloon was similar to the other studies. So in patients randomized to DCB, all attempts should be done to have optimal predilatation before DCB application. So the use of cutting of scoring balloon, high pressure balloon, atherectomy device, intravascular lithotripsy was left to operator preference, such as imaging with IBUS or OCT or functional assessment. In patients with randomized to the balloon, the crossover to the DES was allowed in case of suboptimal lesion dilatation, so residual stenosis more than 30%, high dissection, type C or greater, or FFR functional assessment not adequate. 3,341 patients were randomized, 1,671 to solution strategy, and the remaining to the stent strategies. And they presented the 1 year follow-up at TCT. The major clinical characteristics, you can see here, high bleeding risk occurred in 18% in the solution and 16% in the DS strategy. Acute coronary syndromes, 33% in both groups. Looking to the vessel treated, the left LAD was treated in less than 50% of the patients, proximal LAD 18% versus 19%. They don't have at that time the QCA analysis, but presented the device size, which was more than 3 millimeters in the more than 65% in both groups. So that means that the vessel was quite large. Moderate to severe calcification, 25% versus 22%, and complex lesion according to the HCCHA classification in more than 65% in both groups. Looking to the lesion preparation, as you can see, cutting of scoring balloon was utilized in 29% roughly in the solution versus 80% in the DES group. Rotational atherectomy or lithotripsy in 3.6% versus 2.5%, and imaging per lesion 16 versus 19%. In the solution DCB strategy, crossover to the stent occurred in 18% of the lesion and 21% of patients. The primary endpoint of target vessel failure at 1 year occurred in 4.4% in the DES strategy and 5.3% in solution DCB strategy. The non-inferiority criteria were met. So the study, to me, suggests clearly that the strategy of DCB approach, elective DCB approach, is safe. We don't have to worry about acute complication. Indeed, as you can see here, cardiac death was similar in two groups, less than 1%, target vessel MI 2.7 versus 2.6, and also here acute lesion thrombosis or subacute 0.5% in the solution, 0.4% in the drug-eluting stent. So that means that the strategy of DCB in de novo lesion, also in large vessel, is safe. We don't need to worry about the risk of acute MI or lesion stent thrombosis. Looking at the subgroup analysis, they show that there may be some interaction in high bleeding risk patients and in the severe to moderate calcification, showing a better favoring DCB approach, but this, of course, is only hypothesis generating analysis. So the conclusion of the resolution de novo, to me, is most important. The concept of the strategy of DCB approach in the novo lesion is safe. We don't need to worry about the acute complication. And of course, we need to wait a long-term outcome, which is 5 years outcome, looking to the difference in the risk of revascularization in the two groups. And the other news we had, TCT was on long-term outcome of this approach of DCB versus drug-eluting stent. This comes from the REG cage-free trial. They presented the long-term outcome. The 2 years outcome has been already published in Lancet. They show a higher events rate in DCB versus drug-eluting stent. And now we have the 3-year follow-up presented TCT by Gao. Just to summarize, the trial is de novo lesions in all instances included, regardless of vessel diameter, non-complex lesions in all instances. And these are the characteristics. So they included bifurcation, not requiring 2 stents, no left main lesion were included, no graft, no CTO, no requirement of atherectomy devices. So the patients, in this case, they randomized after predilatation. So they treated the lesion with the conventional strategy in order to have optimal predilatation with the conventional balloon or cutting or scoring balloon, etc. And if it was a successful predilatation, there was a randomization to sirolimus eluting stent versus DCB. In case of the predilatation was unsuccessful, there was a cohort of patients treated by stents. The primary endpoint was the device-oriented composite endpoint of that target vessel myocardial infarction, clinical and physiological indicated target lesion revascularization. And this is the DCB utilized. They utilized both paclitaxel eluting DCB made in China, this white DCB, and also a sirolimus eluting balloon, the fiber to the, and the other side they had the sirolimus eluting stents, which is the fiber DES. So they compare the sirolimus eluting stent versus a paclitaxel eluting balloon. 2,900 patients were included, 2,272 were randomized after successful predilatation to DCB, paclitaxel DCB groups, 1,100 versus the same number sirolimus eluting stent groups. Looking to the characteristics, chronic coronary syndromes in roughly half of the patient, the remaining had the acute coronary syndromes. LAD was treated in 50% of patients in both groups, proximal LAD in 27 versus 26, 26 versus 28, DCB versus DES. Cutting or scoring balloon was utilized in 68% versus 61, little bit higher in the DCB groups. And looking to the vessel treated, they look to the reference vessel diameter was overall 2.8. So we had a quite, not a small vessel actually, but a quite not more large vessel actually as compared to the previous trial. And looking to the primary endpoint of device-oriented events, at 3 years globally, there was no difference in death, no difference in target vessel myocardial infarction, but a higher rate of clinically and physiological indicated target lesion revascularization. 4.2% in the DCB groups, 1.6% in the stent groups, and the difference was statistically significant. So the global primary endpoint was higher in the DCB group, 8% versus 5%, and it was due to the high rate of TLR, but no difference in MI and death. Looking specifically to revascularization, there was no difference in the urgent revascularization, but only in elective. This still confirms the safety of the strategy. We don't need to have worry about the risk of acute complication, but only there was higher event rates looking to the elective revascularization. On the other side, the advantage of the DCB approach was in the lower rate of bleeding. Bark type 3 and 5 was 1.4% in DCB versus 2.6% in DES group. So DES probably was associated with the lower duration of DAPT. And this is a landmark analysis of this trial. So the difference in the events due to the higher rate of revascularization was observed between 0 and 1 year, 1 and 2 years, but not a longer time between 2 and 3 years. So the disadvantage of DCB occur at 1 year or between 1 and 2 years. Looking to the subgroups analysis, looking to the small vessel and non-small vessel, so the vessel more than 2.7 millimeter, looking to the small vessel group, there is no difference in the DCB versus DS in the device-oriented events. The difference was observed in no small vessel group. The events was higher in the DCB, looking 9.2% versus 4.3% in this. So this subgroup analysis supports the hypothesis that DCB are not so good in large vessel as compared to the drug routing stent. So finally, the study between 1 and 3 years confirmed that the DCB approach does not have a difference in death and MI, but only in the risk of revascularization at up to 3 years. So this, in conclusion, the news of the use of drug-coated balloon in the de novo lesion, to me, are from these two trials support the safety of this approach. We don't the risk of acute complication are not different from is not different from drug-eluting stent approach, even in the both science, in the solution de novo in the cage-free trial. Of course, we need to wait longer term outcome in order to clarify the advantage or disadvantage of this approach as compared to the drug-eluting stent approach in the risk of revascularization. So thank you very much for your attention.
Thank you so much, Carlo. Now, let me, if you can stop sharing your screen. Now, so we heard a lot of evidence, a lot of studies. Tell me now, binary in one sentence. So should I now do more DCB or should I do less DCB? Because you show solution de novo tells you are safe. The Reg cage-free long-term trial actually showed maybe it's not a good idea. So should we now do more DCB or less DCB?
I mean, in the de novo lesion, we can say that in the small vessel, we can do DCB. And also the risk of restenosis is not different. So I'll do more DCB in the small vessel. We need to clarify the role of DCB in complex lesion. Complex lesion means, to me, the chronic total occlusion, the calcified lesion, for example, in patient with high bleeding risk. Because in this subgroup, there are some subgroup analysis supporting the advantage of DCB, for example, less bleeding, less complication. But of course, we need to wait have more data in long-term outcome.
Okay. Now, let me ask maybe the other panelists. For you, how, and I will go with Dr. Chaudhry. For you, how convincing is the Reg cage-free trial for you? Is this, do you take this trial very seriously, or you have your doubts? Because I have my doubts with this trial. What do you think?
Well, one study doesn't prove it has to be repeated, but from the way I look into the data always has been that I don't think there's anything to convince me that head-to-head DCB is better than DES. However, what we have is a lot of safety data. That's point number one. And point number two, even when you have this TLR of, say, 15% in 2 years, which means 85% of the lesions did not require metal. So for me, the biggest thing about DCB is hybrid PCI. If you look into the TLR rates of the studies, which like the solution de novo or some of the others, the TLR rate is incredibly low in both the arms. You never have that TLR rate in a DES versus DES studies, much higher in a DES. So these are a selective group of patients. So in certain lesions, when appropriately chosen, when appropriately prepared, you can get a very good result with the DCB. If you're making it all comers, I don't think there's anything to suggest a DCB can beat a DES in all comers. But in selected cases, it's a very good option, and really hybrid PCI is where it really fits into for me.
The reason I ask this is, in the REC cage-free trial, that trial actually tells you don't do DCB in low-risk lesions at all. And that's conflicting with the solution de novo, which tells you you are very safe to do DCB lesions in DCB treatment in low-risk lesions. And that's where I have the problem. So whereas we have, with the solution, this is a balloon I use and I know. And with this white balloon, I don't use, I don't know. And it was tested before that in a trial with 200 patients against sequent please. So it's an unknown balloon. So my question is this really the DCB, or is this just a bad DCB? It could be that it's just not a good product.
Yeah, I mean, that all DCBs are definitely not the same. And for sirolimus balloons, it has to coat to a certain extent. So elute to a certain extent, not coat, sorry. Backlit axle, you can have a backlit axle coated balloon with much less elution and get a good result. So your balloon, which you're saying solution, is of all the DCBs or DBs, whatever you want to say, it probably has the best elution curve. So if you go by technology, solution is quite a unique product, especially in the sirolimus coated balloons. So there might be a difference of the balloons explaining the results as well, which you're pointing towards.
And I think, thank you so much. And I think what we have to really tell also the audience is that very often we try to generalize. We use one balloon and then we say, well, it's the balloons, or we use one DCB and say it's the DCB. And probably we have in the future, we have to do more head-to-head trials of DCB versus DCB, or maybe like the Sparks trial, which will be DCB versus stent, because just taking, just extrapolating from a DCB to the whole group, it's probably it's unfair. Okay, any other comments from the other colleagues regarding the talk of?
Yeah, so I mean, this was again a very interesting finding that I noted in Dr. Carlos' slides. Again, as with stents, if you look at the de novo data, the failure rates is in the female subgroup. It's still DCB is not doing well. It is favoring stents, and a lot of failure in de novo was in female patients. That's not what really I see in my clinical practice. I mean, I don't so I have had 2 DCB failures this year, and one was a male and one was a female, but I don't see a female preponderance in DCB failures. So how does it fare out in your practice?
Well, so I was in the session where it was presented, and I asked actually the author or one of the authors this question, and we can discuss this. I think it has something to do with lesion preparation. In this REC cage-free trial, 60 to 70%, I think, of the patient, they use the cutting or scoring balloon. Now, take the female vessel, small vessel, maybe not a very thick media, and go in with a cutting balloon and destroy it completely. Then, yes, of course, I think I expect there maybe even a bad outcome. What we have started to do is really try to tailor our therapy according to OCT. So if we see that the vessel is small and it's not very diseased, then maybe first go with an NC balloon before we cut it and destroy it completely. So I think we have a lot to learn also in gender differences, treatment between female and males. Maybe using the same lesion preparation is not a good thing. Mohammed, what do you think?
Yeah. I mean, I think Anirban hit the nail on the head. I think we can't use it for all comers. We have to learn how to use it. So in answer to this question, shall we be using it more? I think yes. Ideally in a kind of a very structured way, because now everybody doing what they think is right and everybody's practicing differently. It'd be nice to have it in a kind of a set rule. This is what you do and this is what you don't, but that's never going to happen. But I think the more we do it, the more we learn, and we're all very clever. My thought about all the studies, there's not a single study that will give you the answer, because you look at how it's recruited and the kind of patient, and there's always a differences. Even the solution that was presented, I mentioned that a little bit earlier. the non-inferiority margin was set at 50%. Even at 2.5% event rate, the drug-eluting balloon are still going to be okay. I think what we know right now is drug-eluting balloon are safe and you could use them. But in complex cases and multiple use, I think we have to be a little cautious until we see a little bit more data.
Okay, I think the time is really now 5:30, so we are 30 minutes behind schedule, but we have had a lot of discussions. And now I would like to ask Professor Abdullah Shehab from Dubai. And when I saw his cases, he does a lot of crazy cases in ACS, and there were a lot of questions in the chat about ACS. So now we need some really good cases from your side, and tell us how to use DCB in ACS. Thank you so much, Abdullah.
All right, thank you very much. Let me share my, I don't know, it's not able to share. I'm sharing something different here. Stop sharing. Let's try again. This is mine. Can you see it?
Yes, now.
Okay, let me make it bigger. Okay, you see it now, yeah?
Yes.
Right, thank you very much, everyone. It's really a pleasure to be together in this meeting. And I think for audience, you've seen everything. You see the nice journey of the DCB from how to prepare the lesion by our chairman today, and then move to the, not to add more metals, then to small vessels, CTOs, and finish with the, what the evidence. So I'm going to share with you maybe the last frontier in the DCB. This is the acute coronary syndrome and STEMIs. Right. I think there is a call for innovation, and no doubt, we as a curious, always as an interventionist, we want something, as minimalist as possible, something less harm to the patient. So we've seen from the stent, I know we reached a stage where it's very mature now, the nicest stent available. But despite of that, there are still long-term risks of reintervention, and permanent implant is there, and stent thrombosis. So nothing better than, having the biology restore and no metal inside, nothing better as they call it, our friends, to be nature. So some of the backup practice for the using DCB or no metal, these are small studies. There are signal there. There is, telling us converging evidence, I call it, converging. So, collectively, some small randomized clinical trial and different paclitaxel and some of the everolimus going that way. It's about safety, about, there's no hard kind of evidence, large randomized clinical trial, and I doubt one day we'll have that. But anyway, from real life as well, we have some registries, and in UK and other places tell us that this is again safe and feasible, and hopefully, I don't know, is that possible, equiposed to have a randomized clinical trial in this situation where the life-threatening, you just say, okay, people worried about the arteries, there's too much thrombus there, recoil could happen, you might lose the patient, you cannot sleep, there are lots of people talk about things like that. But of course, everyone talks today about one thing, and I think we should agree on this, and we should really work on this. I think we should have a randomized clinical trial about this one. Lesion preparation is everything. I think it's not DCB, this is the thing. If we're able to do this well, then I think, we can assess, because what happens at that acute stage, it doesn't matter. You want to make sure the things are safe. Lumen is open, artery is open, flow is fine, patient is stable. That's what you want, acute stage. Remodeling, all this depends on what you do at the beginning, at that stage. So if you do things properly, of course, these are some of the old criteria. I share it here because this is what people know. We come with a new one. Hopefully, we're going to share that in future with our consensus paper. But these are the things we know, is to use most of the time, use the specialized balloon. I think because you want to have a organized dissection, because, you want to paint at the end. When you paint, you want that paint to go inside, to the intima, to the media, to advantia, to get that result. Otherwise, you just plain balloon. So plain balloon equal to DCB when it's not done proper dissection. So if you don't get dissection, you will not get the good results. Okay, that's need to be studied, of course, more and more. So DCB therapy evolved. We know all that, and we've seen it. And I think every time, every conference we go to, there is something about DCB, some new studies. So I believe we maybe stent when we must, but DCB when we can. And that should be our routine. DCB, I mean, leave and paint at the end when you are happy. Paint at the end. Just paint it. Don't say DCB issues. Is our issues if we don't prepare the lesion. So with the Portagee is a new technique, is this wing seal, which give you a controlled uniform paclitaxel delivery, which is under pressure like a sponge. You get that released when you open nicely. And the good thing about it, you can use it in 3 segments, and especially with our diffuse cases when we get and sometimes in STEMIs and non-STEMIs, I'm going to show you some cases, you will see that. And the non-compliant they have is very nice as well, to give you a really homogeneous, nice effect of the. So the case here, most of my cases, I mean, these are the one I use Portagee. Of course, I have use other paclitaxel cases, I mean DCBs, but this is a young man. All the risk factors you can see here, and you can see here with the RCA, you don't know. I mean, I was really not sure about this patient. 2 months of history, but troponin was positive. So then echo positive, so we no need to do anything, stress or anything. ECG was unremarkable, to be honest with you, but echo was, so that was a lesion. And this, of course, you don't know what to do. You just go with your wire, as I think Dr. Muhammad does for his CTOs, but this was not a CTO for me. But again, we prepare the lesion. I always use the specialized balloon here, a scoring balloon, different pressure. I go to the maximum when I'm happy. I don't go immediately. I takes time until I'm happy. I get the flow, TIMI 3, and things are fine. Then I say, look, now why should I put a metal? Any reason put a metal? I ask myself, then I say no. Then I use the DCB. Here I use the DCB 3 places, as you can see, the proximal, mid, and the distal. And that was the final result. Maybe slow flows a little bit, but that's improved after intracoronary nitrate. So this patient now is on, what I do, this patient, non-STEMIs, I know maybe we have no studies. We always use the stent the way we do with the stent, but this one I use 1 month DAP, then I use SAPT after 1 month. And it's been my patient like this. Most of them, I've been following them for like 5-6 years with different DCBs. A younger man. History of hypertension, DLP presented with chest pain, again, non-STEMI. This one you can see is multi-vessel, and RC is there, OM, LAD, proximal, but which one is the culprit? I mean, you don't know. You go with the one which you think is more, so I thought this OM is so I went with that one. Again, the same strategy. You prepare the lesion, and that should be your way, and which I did again with a specialized, you can see specialized scoring balloon. I go to the maximum, so I can get similar to the DCB length and the diameter I go with. Once I'm happy with that lesion, which you can see here is already back to normal, not a stent-like, but it's back to normal. That's what I want. I mean, the good thing, in these cases, this acute coronary syndrome and STEMI, you don't have no background of the patient. You don't know. They're coming acutely. You don't know whether they can afford medication. You don't know whether comorbidities. You don't know if they're going for operation. So the minimal you do for this patient, the less, if you can avoid the metal, that's the best for the patient. But again, as Dr. Muhammad always say, there is always tomorrow. So should not be in hurry with these kind of patients. So this is what I did. Again, also, I thought, why not also to deal with the LAD that day? I know it's not maybe the optimal I got, but, this was the lesion. I mean, there's some residual, but that's not the culprit. The culprit was the OM. So that was, I'm not that disappointed with that kind of flow, because I know it will grow later on. Can you hear me?
Ja? Nachher, okay. Danke, ciao.
Right. And the next case is, again, an anesthemy. Again, I did the same thing. You can see all are young people, and this is multivessel disease here. You can see as RCA, again, proximal OM, and proximal LAD. This patient is at the end, when I did a DCB, he was left, you can see here again, same procedure. I went with a scoring balloon, and this was the RCA, which I'm okay with it. A bit of residual stenosis there, but TIMI flow is fine. Same with LAD, but you can see that at the end, you can see all the lesions, there are some dissection. All the lesions, there are some dissection, which is I'm happy with. As long patient is fine, stable, flow is fine, and there's no much ST changes, so I'm happy. Again, I've been following this patient for almost like 9 months. Again, clinically, patient is fine on SAPT only with one antiplatelets. Now, STEMI case. You can see here, patient with inferior RCA, just one injection, you can see secluded. So we want to look at the LAD. LAD, you can see also disease, young man, and with that kind of diseases. So we went with RCA, you can see here. So what I do, I know there's a plaque rupture. I want to make that plaque rupture, stabilize it. So I use a scoring balloon. I don't use NC balloon. I don't use other balloon. I go with the one which I'm sure will give me the best dissection or a good dissection, which I'm happy with. Once I do that, then I say, okay, the patient is now, it's time to paint it. Once I paint it, then I'm happy. You can see the result is not bad for somebody in acute. I have no idea. I don't know what they can afford. I don't know if tomorrow they're going for operation. I don't know if I'm going to see the patient, tomorrow or after tomorrow, bleeding happens. I don't know. So this is what happened. Again, this patient come to me after, a few months, again, patient on one SAPT. And the final case, this one you can see here, is patient had proximal and mid was totally occluded, but the proximal was like 70% stenosis. Again, this is STEMI. Again, this patient wants to wire it. Sometimes I go with the aspiration. This is selective cases, but this case, after really going with the balloon and that things open. I know that things debris goes down. That's fine with me. I use 2B3 inhibitors, by the way, a lot in these cases because these are acute cases. Any antiplatelet you will give them will not work. The only one is on board is heparin, which is not enough. So I have to use DCB. And you can see here, this DCB, I use it in 3 places, proximal, mid, distal, and that was the final result. There was some flow at the end below because of the clot going down. That's fine. So patient, this one also left with one dual and adapt and then SAPT at the end. So simpler therapy, better biology, cost and safety, that's the most important thing. The DCB represent, I think, a modern PCI philosophy is what I believe, and a precision preparation. I think everyone agree on that. That should be our goal. That should we do. We should not talk about DCB unless we do this properly. So by doing that, we are able to, biological healing and minimalist in action. So prepare with hardware. That's what you do. Everything you saw with our moderator today, all the tool you use it to prepare the lesion, then treat with biology, of course. So every case should begin with one guiding question, I think. Can I achieve a stent-free result safely? If yes, then go with DCB. I think STEMI, as a patient, we have to be patient here. We should not, I think the patient is the power. So restore the flow, respect biology, and leave nothing behind. And the best implant is no implant. Thank you very much.
Thank you so much. Very brief, nice talk. Great cases. Okay, now we will have a final discussion round here, and we have to ask some questions from the audience as well. And as I told you, there is a lot of questions about ACS. So people are very excited of using DCB in ACS. And the question is now, the antiplatelet therapy. Do you give your patients a 1-month DAPT, or you go by the guidelines and still give 12 months of DAPT after using a DCB in a STEMI or non-STEMI?
Yeah, as I said at the beginning, that guidelines for the, and I think it's done mainly for the stent. I know there are some, they talked about even non-stent cases, but that lesion is different than when we do it with the ballooning and DCB. So for me, when I prepare the lesion and I leave nothing behind, I have nothing to worry about that lesion in terms of thrombosis. So I go DAPT, although I have no evidence, for 1 month. Then I go SAPT after 1 month.
And when you go SAPT, you go with aspirin or you go with a P2Y12 inhibitor? Single antiplatelet.
I go what patient able to afford. I normally go with the clopidogrel or ticagrelol if the patient able to afford. If not, then aspirin, and they are so far been fine, no issues.
Okay, so maybe some voices from the panel regarding antiplatelet therapy. We heard from Mohamed, you use sometimes 3 months, but you think 1 month is safe. How do you do it in ACS? Short answer, please.
It's still probably 3 months minimum, because we know that even if you don't treat medical treatment, you still require dual antiplatelet therapy, at least some of the evidence. I was going to just ask Abdullah, this has always intrigued me. A lot of us do things because it makes us feel better, right? And unless you prove it, and this was going back to my point about doing comparing drug-eluting balloon with the normal balloon. In the acute MI, the thrombus is laden around the wall. It's even if you aspirate, if you do OCT, you always see thrombus on the wall, right? When we put the drug, the drug-eluting balloon, it should work by the drug leaking into or coming to the wall. How does it work in MI? And is it just the effect of the ballooning itself and the flow? How do you think that the drug works? And is there any study that tells us if in pigs or whatever it is, when you put the drug-eluting balloon, the drug kind of gets into the wall, or how does it work? That's something I always ask myself that question, and I don't know.
No, that's fine question. I think ask ourselves all the time. But as we all agree, we will not go with that last step unless you are happy. صح? You TIMI flow 3, you find the lumen is already open. So that's it. I mean, that is
if we don't do the
dissection is there, doctor. You made the dissection, which was a plaque rupture. You kind of what we do when you get dissection, you are a master of this. You just make the dissection better. What we do when we get a perforation, for example, the same thing. You do that, then you apply whatever you can. So once I have the TIMI flow 3, the diameter is fine, and I just deliver my DCB, and it will go inside. That's what I know.
But so I will be now very provocative. In STEMI, the patients come in proximal LAD, huge ST elevation, and then I have the chance with one stent to finish the case in 1 minute. Wire stent done. And I can bring the patient back and optimize. And now Professor Shehab says, no. Let me do lesion preparation here. 2-0 balloon, 3-0, a bit of distal embolization. Let's use a scoring balloon for the sake of using a DCB, which we don't know if it will be superior. So how do you convince me that if you come as a patient with a proximal LAD occlusion, that I should go with DCB and not with a stent? Imagine you are the patient. Yeah.
You're asking me a question.
Yes,
You're asking me.
Yes.
Please come visit me in my cath lab and see how I do it. No, really, because honestly, most of what you say, people say, I'm not sure you're doing this. Most of people, what they say, this is their imagination. It's not true. I don't use that much of a balloon. I use only one balloon. And that's it. Then I go with the DCB. I don't go bigger. And this has been really the most easiest one I found to use DCB has been the STEMI cases so far. I never, I use like 6 or 7 stents over like 7 or 8 or 6 years. And this been in the cases where I need to do CCS cases, not ACS cases. None of the ACS cases I've used a stent.
Okay, very, very interesting. Yeah, I really have to visit you and find out how this works. Now,
we do a live case. Sorry, Florian. I mean, the same. We know that Simon Eccleshaw here has always used a drug-eluting balloon. There's a couple more guys I know, they hardly ever use stents. So they do believe, and it does work, and the outcome is not as probably not the same as stents, but not as bad. So we know it is safe, but a question remains, I suppose, in all our minds, how this works. And when you believe in something and you do it, you continue to do it, and because it's serving you. We all depend on our experience and what we see. If you would have thought that's harmful, causing any problem, you probably would not have been doing it all this time.
Yeah, and so in my opinion, and that's why I have shifted in the beginning, I was in this stage of using DCB for everything. Now I'm in the stage that primarily I use DCB where I know stents will fail. And I treat a lot of patients where I know the stents don't perform well. Now, to use in ACS, where I think stents in STEMI, for example, stents work quite well. I think we need a trial, and I would be the first to participate in such a trial, because I think we need evidence before we really go into this broader use for everything. That's why I asked the question: is stent only a bailout? And I think I agree, it's probably not yet, but we are getting there slowly but surely.
But Florem, I think that's a very important point, because to me, the age of the patient also plays a major role in whether I put a stent or not. You only get somebody that's less than 50, you put a stent in, we all know that it's exponential. Over the years, it will continue to cause a problem. So if I could solve the problem with no stent behind, because again, Abdullah mentioned, I always say there's always tomorrow, you could always come back and do something else. Absolutely. So if somebody young, and instead of putting a stent, if I could get away with a drug-eluting balloon, absolutely. But going back to your point, if in the other hand, there's a lot of complex disease and if you put a stent, it's going to fail, then again, regardless of the age, just use a drug-eluting balloon. It works and it's safe. Just do it.
So one more question from the chat. So how, and here I would like to take the opinion of Dr. Chowdhury. So the protege, do you inflate it to nominal pressure or do you go bigger? How do you size it, and to how many atmospheres do you go with protege?
I size it 1:1, but because it offers you multiple inflations, and you can see in various lesions, if this is LAD, for example, you can't size to 1:1 if you're doing multiple inflations. So you size 1:1 sort of in the middle of the lesion. So when you come to the proximal third inflation,
One
that tends
question,
to
sorry
go.
to bother you. So 1:1 to vessel size. So you size it like a stent, or you size it smaller? Do you size it according to the lumen or to the vessel?
To the lumen.
Okay, so you size to the lumen, because I think this is who else. Let's ask the other. So Dr. Rupesh, do you also size it to the lumen, or do you size it to the vessel size? Do you size it like a stent, or do you size it smaller?
I size it to the vessel actually, not to the lumen. And I don't go above nominal because, as pointed out with Professor Ingrid, it's just a drug delivery device. I don't have to prepare the lesion or dilate the lesion using that balloon. So I'll just go at the nominal pressures.
Okay. So
Can I just rephrase that? I mean, when you ask the size of the vessel, obviously for that you have to have imaging. But what I'm trying to say is that if I choose a stent or I choose the balloon, the size is the same.
okay, so I do it differently, and here that's where I wanted to get to disagree, because, and you can correct me if I'm wrong, but I find very often, if what I don't want to achieve, and I do repetitive OCT imaging, so what I don't want to have is the dissection with the final balloon.
Yeah,
that costs me time. That costs me maybe more balloons. I don't like that. So that's why I usually prepare the vessel and then I size my balloon according to the last balloon used for lesion preparation. So if my last balloon used for lesion preparation was 3.0, I will usually use a 3.0 DCB. Who else does it like this, or do you guys go bigger and I should go bigger? Maybe I'm wrong.
I go this more or less the same, because again, I mentioned that it is a drug delivery tool. You prepare the vessel, you've got the lumen, and you have to size it according to the vessel. You're not going to go in a 4.0, go a 3.0 vessel, a 3.0 balloon, because you need to be against the wall. And this is why the nominal pressure is important, so you don't cause a dissection. The last thing you want, you prepare the vessel very well, and there's no dissection. You take the drug-eluting balloon and you go to high pressure and you dissect. That's not what you want to do. So I think it's really important to make sure that you size it correctly, 1:1, and let it deliver the drug, and that's all what you need to do.
So guys, do you size, so Dr. Rupesh and Dr. Anirban, do you see dissections with the bigger balloon, or you don't see this a lot? Maybe we are just too afraid.
Yeah, you obviously got me thinking about what I do, and what I realized is in the calcified vessels, I do exactly what you do, because my preparation in calcified vessels is much more thorough. On the contrary, if it's an ACS lesion, you have taken a 275 balloon and you give a nitrate and you've taken a picture, and the vessel looks bigger. So though
I think we are
that
all
point
doing
I
the
might
same
be
thing and
sort of
probably phrasing it in a slightly different manner.
Not really. I mean, if I use a 3.5 stent, usually in those lesions I use a 3.0 DCB, because if I use a 3.5 DCB, it's just too big because the lumen, and this comes from intravascular imaging, because I see that the lumen is for this 3.5 vessel, where I would use a 3.5 stent, the lumen is not 3.5, it's 2.8, 2.9. So that's why I don't stretch it to 3.5 to cause a dissection.
So
But
suppose if
Lauren,
it was a 3.5 vessel and there was a calcific disease, you used, as per the lumen, used a slightly undersized cutting balloon. You would go with an undersized drug-coated balloon, or you would probably use a nominal pressure at 1:1 nominal non-compliant balloon.
So I probably would downsize the balloon a little bit, inflate it at 6 to 8 atmospheres, inject a little bit of contrast and see if the contrast is propagating distally. If I have contact, then I'm fine. If I don't have contact, then I would quickly inflate it to more to get more contact with the vessel wall. Because with a 3.0 balloon, if you go to 12 atmospheres, you can probably reach 3.5 in a diffused vessel. You know, if the vessel is not very compliant. So yeah, Mohamed.
That's the most, it's the contact with the wall. This is, again, I said that, I repeat myself again, it is a drug delivery tool. So it has to kind of touch the wall to allow the drug to go to the wall, and that's the most important bit. If 3.0 is getting you against the wall, that's fine. This is why I think the Protege has got the non-compliant and the compliant. So if you go with the nominal pressure, I think you probably not going to cause any problems, but you have to be careful, so not to cause a dissection of your loss inflation.
Let's speak a bit about bifurcations. Now, in some bifurcations, either treated with stent or DCB or 2 DCBs, you might need to do kissing balloon inflation. I think this is the final topic we cover for today. So how do we treat bifurcations with DCB, and how do we apply kissing balloon? Dr. Grigori, how do you use kissing balloon inflation in DCB treatment?
Well, actually, I don't personally do kissing balloon with DCB. I do sequential. So I inflate first the inside branch, the DCB, and then in the main vessel. I don't do kissing because I don't know what is the delivery of the device when we inflate both balloons together. We don't have any in vitro data on that. So what I do is sequential inflation.
But for example, you do a LED diagonal. You do the diagonal, you do DCB, yes. You send the LED, and the diagonal is pinched. What do you do then?
Okay, if it's pinched, but there is no major flow limitation, but only a pinch in the ostium, I don't do nothing. If there is a flow limitation or dissection, I do a dilatation with a new balloon.
Okay.
It depends on the flow.
Lauren.
Okay, very nice. So who else? Yes,
sorry,
please, Mark.
I just want to, because this is a question gets asked all the time, and I would be interested to hear what the panel think. I know what I think and what I do. Often people hesitate to do anything once you've used a drug-eluting balloon, you try to avoid doing anything else. Let's say you're talking about bifurcation, you did the side branch and you did the main branch, and you find that the side branch, after the drug-eluting balloon, the flow is not as good or pinched. Would you be able to go the normal balloon after you've already used the drug-eluting balloon? Would somebody hesitate doing this?
Dr. Rupesh.
So like, this is a question which I have been pondering on, and now as I got to use more and more DB, I believe it's pretty safe to use another balloon, because that's how the drug works. If you believe that the drug is just sticking to the lumen, then that's not how the DCBs work. Ultimately, the drug diffuses inside the cells, right? So then I think it's safe to go in with a second balloon.
Abdullah?
I mean, so look, everyone agrees that, the last step is the DCB, so that DCB should deliver the drug, and it should be contact with the wall enough, at least 28 to 32 seconds. That's the latest abstract. So you don't need to, so that's enough time. So what happened after that? You mean you get no reflow, doctor?
No, if you have a pinched ostium, or you want to do another balloon, but not a drug-eluting balloon, does it matter whether you go back after the drug-eluting balloon? I don't think it does, because intuitively and how the drug works...
To the branch, you mean? To the branch?
Yeah. Or the branch or the normal vessel. The drug has already gone to the wall. It's not in the lumen, so it should not be washed away. It's in the wall. So you use a second. People sometimes hesitate doing IVUS after or OCT after the drug-eluting balloon. I don't think it makes any difference.
No, if the branch get pinched after you do the main, unless you are not happy, you can balloon it again. But I don't normally. I just find
But the
it will
question,
regrow.
so Abdullah, so what Mohamed is pointing at is very important, because many people don't like to manipulate at the lesion you just treated with any balloon or device, even IVUS or OCT, because they think that you will wash out the drug. And I think if the drug is so washable with a balloon,
No use.
No
use.
No use.
Exactly. I think this is the message I wanted to get out. Honestly, if you, after you delivered the drug and the drug-eluting balloon, if there's a clinical need to go with another balloon or with IVUS, don't hesitate, because the drug in theory should be in the wall. It's not in the lumen. It's not going to be washed away. If it's in the lumen, the blood flow will wash it away. And then it's a psychological treatment rather than a proper one. So there's no hesitation. And this is the message that needs to go out, because I get asked this question a lot. So no, it's the drug has been delivered. Don't worry. Go ahead, and it's like putting
I agree. This is a very common doubt that's there. I remember doing the live case for the drug-coated balloon in the national NIC. I think Dr. Florim was on the chair that day, and this was again brought out. And we were doing an IVUS after a DCB, and somebody on the panel was like, "Oh, you're going to disturb the drug," and so that's not how DCBs work.
Exactly.
Yeah, I want to say one thing about acute coronary syndrome STEMIs. I'm not talking about operator myself. I really need to think about the patient in front of you. Most of these patients are young, as Dr. Muhanna said. This is what happened in our region. Most of them, we have no idea what their background, how much they can afford. Really, the power is not to put a stent that time. I think to be a bit patient. Be patient. Get the artery lumen open, restore. If you want to put a stent, next day put it, but that day try not to. Which I've done for last 6-7 years has been very safe, and patient really thanking me. Most of patients, they stop their medication. So think about the patient. I think that's the message from ACS.
Thank you so much for this nice comment. Now I think we have to come to a conclusion. It was a very nice webinar and a lot of great discussions. I hope the audience enjoyed it. And one thing maybe for the audience, today I had a patient who came from far away just because he knew that I use DCB. So I think in the future this will become our marketing tool, because people will probably avoid doctors who are not experienced with DCB, because it's really the new generation of patients, I think, who don't like stents, don't have a foreign body. This is like driving an electric car. Nobody really knows if electric car is better for the environment, but everyone thinks it's better for the environment. So
that's a very good analogy, because the hype and the kind of the excitement about drug-eluting balloon is phenomenal. And we're using, and as I said, everybody's using a little different, and everybody doing them in a different way. But they're here to stay. That's the main thing. And I think we need to learn how best to make the most out of them.
So I would like to finish with every one of you saying one sentence about DCB therapy for the future. I will start with Dr. Rupesh. One sentence, DCB therapy for the future.
So DCB and DCBs and DES are going to go hand in hand, and both are going to be here. And ultimately, that the hybrid strategy is going to increase and improve the outcomes.
Thank you. Dr. Carlo.
So I believe that in the future, the stent will be utilized as at the beginning. The stent is being invented to solve the problem of the acute occlusion to the dissection, but not to prevent restenosis. So I believe that in the future, we will have drug-coated balloon treatment and stent only in the segment where there is a risk of acute occlusion.
Thank you. Dr. Abdullah.
Right. I don't know what to say, but I think it's a purity, restoration, freedom. It's something good for the patient.
Okay. Very poetic. Dr. Anirban.
I would say that it's a fantastic technology, and we should make justice to it. So make sure that it is used as your therapy delivering unit rather than a treatment unit, so that we have the best out of it.
And Dr. Mohamed.
Yes, I still think it's a hybrid approach is going to be the future, but we're going to see more and more of the drug-eluting balloon, and we're going to learn more and more, and it becomes the norm in day-to-day practice. I don't think stents are going away.
Thank you so much. I would like to conclude here. It was a great fun. We are 1 hour, I think, late, but I hope everyone enjoyed it. Thank you so much, and looking forward to meeting you again in a webinar or live on a conference. Thank you so much. Goodbye.
Bye-bye.
Thank you, everyone. Thank you. Goodbye.
Thank you.